Oral presentation 16. Critically ill COVID or non-COVID, have you made the right decision? Experience from the medical ICU of a tertiary care center in Sri Lanka. The authors are Deshan Priyankara, Manoj Edrisurya. The presenting author today is Manoj Edrisurya.
Good morning. Thank you, CCP, for this opportunity to present our work in our ICU. So I'm Manoj Edrisurya and my colleague Deshan Priyankara. We both are consultant intensivists in National Hospital of Sri Lanka. And of course, we would title our work as critically ill COVID or non-COVID. Have we made the right decision? So I think if you look at the definition of pandemic that we are currently facing here, even in Sri Lanka and the whole world. So WHO defined it as an outbreak of infectious disease, which is not respecting the international boundaries and spreading across the world. And we are time to time facing different pandemics, outbreaks of diseases. And of course, this may be one of the pandemics is much devastating. The effects quite similar to one that we are facing today, which was the Spanish flu in 1918. So this time, this well-known novel coronavirus, SARS novel coronavirus or the COVID-19 started in one of the meat shops in Wuhan, and it spreaded across the world within a very short period of time, as you all know. And it has affected regardless of whether you are a affluent or a poor country, and everybody is facing the challenge, and we will see the enormous effects probably in time to come. And Sri Lanka was no different. Within a very short period of time, the disease came to Sri Lanka as well, and we were not prepared, and we were scared, and people were really struggling to face this. Guided by the WHO recommendations, government has taken some measures, including closing down the schools, airports, lockdowns, and etc. And they were basically trying to contain the disease to minimize the impact on public as well as on the health sector, which is very, very strained. Even by the time of this pandemic also, we knew that we were running over the surge capacity. So the provisional clinical practice guidelines came in a quick succession, and they were basically recommending us to take measures to improve the outcome of this COVID while increasing the surge capacity for ICU patients when it comes to the critically ill, and also without compromising the care towards the non-COVID. And irrespective of all these recommendations, we saw a lot of chaos. People are struggling, at different countries are taking different measures, and we saw the results, and we are going to see the results in the future as well. In this guideline, it was recommended that when it comes to the critically ill patients, you need to create a cohort ICU to keep the patients for a while until the COVID status was excluded if you are really, really suspecting COVID. So NHSL in that sense was considered as a non-COVID center for the simple matter with all the available subspecialty without compromising the care towards the non-COVID. So idea was to screen them if positive to transfer to a center which is designated for COVID. So if you look at how we prepared in our intensive care unit, which is not a unit designated to accept the COVID positive patients. Anyway, we thought that this is a very uncertain situation. We have to take measures to face this. Probably this may be the best time. So within a very short period of time, we took a lot of steps to change the structural environment as well as the functional and other stuff. So basically, idea was to deliver maximum care towards the suspected patient, and once the COVID status is known, to transfer to a relevant place. Even if it is non-COVID patient, then the patient is supposed to go to another ICU. But sometimes there were not much of facilities available in some of the other ICUs, and MIC was the only ICU full-time run by the qualified intensivists. So even if the COVID status was negative, we used to keep some of the patients towards better outcome. Sorry. So objective of our work was to assess the characteristics of the COVID suspected critically ill patients admitted to MICU NHSL as the triage ICU. So by that time, it was not anymore called as the MICU because it was a triage ICU. So, so it was a retrospective analysis of the computerized data in the ICU. We collected all the data over a period of 3 months. This is precisely during the first wave. And a couple of things that we have observed is very little number of patients will become critically ill. And also during the first wave, we knew that there was no community transmission. So most of the time, it was very much predicted which patient might be COVID positive, different to the current situation. So if you look at the results, so most of the patients were male, 60%, and most of them came from the Western province and Colombo suburbs. So if you look at the other demographics, mainly the comorbidities, we know that comorbidity is the main factor affecting the critical nature of this illness related to the COVID. 42%, 42.7% were not having comorbidities. So probably you might say there was no reason to suspect that COVID deteriorated due to the comorbidities, but there were a number of other comorbidities as well. And if you look at the 3 cardinal features of COVID: pneumonia, fever, cough, dyspnea, and there were all 3 features are present only less than 20% of the patients, especially when it comes to the critical illness. You might expect most of these features to be present. And main reason for hospital admission, it was interesting to see that there were a number of reasons for hospital admission in turn to come to the ICU, and close to 20% of the patients here, 20% of the patients were due to trauma admissions. And of course, because of this fear psychosis, they actually didn't get the optimum care, the trauma setup. Instead, they were just transferred to the triage ICU, and it was a bit of waste of time. And we need to assess what was the end result of those patients after excluding COVID. And main reason of ICU admission, it was the mechanical ventilation and the other organ supports delivered to a reasonable number of patients out of these 82%, and 82 total number. And of course, we are admitting roughly around 60 patients per month to the ICU, and over 3 months, you would expect close to 180, but we were basically admitting less than the capacity of our ICU. And some of the patients were just for the observation and oxygen therapy, which was lesser degree of care, which would have been provided in a different place rather than utilizing these the ICU facilities. And reason for COVID suspicion, if you look at the different symptoms and high risk area alone without any symptoms, around 1/4 of the patients were suspected simply because of the high risk area. And that was the main reason to come to the ICU in that percentage. So if you look at the organ support, as I said earlier, oxygen therapy was oxygen therapy was delivered to 53%. And of course, there is overlap between the invasive mechanical ventilation, because sometimes they might initially need oxygen, or maybe they might need later on. So conclusions were there was significant number of admissions due to anxiety and lack of dedicated facilities. We need to assess the outcome of those patients who went to the other places and effect on the non-COVID patients. Thank you.
We can go ahead with the questions.
Okay, thank you. So finally, were there any COVID patients in the sample?
Sorry, there are no single COVID patient identified during that admission. So all the COVID negative, and 23% of them actually died, and that was roughly the percentage of mortality related to the critical illness. And probably some of them didn't really have the optimum care, for example, the trauma patients.
So COVID negativity was confirmed by at least 2 PCRs.
Yeah, so when the suspicion was high, it was 2 PCR, but when there was a mild suspicion, it was only single PCR.
So whether your ICU is dedicated to COVID, or did you have other patients also?
So initially there was a confusion, everybody was uncertain. So initially we thought, because if we are getting positive patient, it is not good to contaminate the other patient. So we evacuated the ICU. We accepted only the COVID suspected patient. But later on, we realized that we are not going to get the way that the pandemic was controlled later on. So we decided to take both types of patients. So we never got a positive patient until recently.
Was taken by who? From the ICU team, or was it a purely a decision by the physicians?
You mean the decision to admit the patients?
Decision to the ICU. Did you have any say about, to take or
It was the multidisciplinary discussions were there with the hospital authorities, so there was so much of deliberations. But only thing is, they found it difficult to set up another triage ICU somewhere else with 2-3 beds because of the, again, fear psychosis. People are refusing to work in that place. So ventilators were there, beds were there, and the wall oxygen were there, but nobody was quoted to work there. So it was simply because of that reason we had to. So that decision was reluctantly taken, because if we are not going to accept, those patients are going to affect them.
Thank you.
Thank you, sir.